Welcome to The Scope with Dr. K, where together we can reimagine GI care.
Welcome to The Scope with Dr. K. I'm Dr. Kaczynski, and we're going to open the show as we always do by stating that the goal of this series is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. We return today to an interview with a representative from the plan side. Actually, our guest is as much of a provider as a plan representative, so I guess we're getting a twofer. The guest today is Dr. Roy Beveridge, who for 6 years was the Chief Medical Officer of Humana. From my interactions with Roy, at his core, Dr. Beveridge is still a physician, though. He practiced oncology for many years until his administrative skills were put to use. He functioned as the medical director of U.S. Oncology, and after its purchase by McKesson, he became the chief medical officer for that organization. Following this, he moved on to Humana. Today, Roy spends his time consulting and advising. As a point of disclosure, Roy advises us at Sonar MD and is on our governing board. Welcome to the show, Roy.
Good to talk to you, Larry.
I want you to take off your oncologist hat and put on your plan medical director's hat. So let's start by talking about the move to value-based care. What are the major issues facing health plans today? What are their most significant problems?
Fee-for-service medicine is a challenge for us all. I think quality of care is a huge problem. And I think equity of care remains a huge problem for, us as a society. It doesn't matter whether you're a plan or whether you're a provider or, you're a citizen of our country. We've got to have good, reliable quality. We've got to have equity in how it's distributed, and it's got to be done in a cost-effective manner. So I think it doesn't matter where you sit in the world, in the U.S. right now, but that's what we've got to focus on.
Is value-based care really a high-level priority for the health plans? And if so, what are the major goals in developing value-based care programs from the plan level? What are you trying to accomplish?
I think if you look at what CMS is doing, CMMI, they're doing the same thing that all payers are doing, which is trying to figure out how there's some control on the fee-for-service spend. And, I think that, for certain subspecialties, like GI, for neurosurgery and things like this, there may be less of a precise need for value-based care. But certainly when you start thinking about primary care for cardiology, for oncology, for a number of other types of medicine, we've got to think about how you rein in some of this wild cowboy type stuff and go back to things that I think the GI doctors have done really well over time, which is, implementing standardization, pathways, guidelines, so that there is a, consistent standard, which is expected by everyone who pays for healthcare and is what is delivered.
You mentioned guidelines, and in my previous life, I was the representative at the American Gastroenterological Association to the Quality Measures Committee and Guidelines Committee. And, we really work hard to develop these guidelines. The societies expend a lot of time and energy on them. And I know the plans favor whenever there's an available guideline, but Roy, it just seems like there's a mismatch between the time it takes to create these guidelines and the enormous need for more and more of them.
Evidence evidence-based medicine is something that we should all want and expect and hope for. But then if that is aligned with a pathway or a guideline, that then becomes, I think, the best standard for society as a whole.
So when you were in your role at Humana, would you keep a library of these guidelines and refer to them when you're approving or overseeing the care provided on the patients that were contracted with Humana?
Well, I think, when you look at what CMS is doing and you think about what all payers are doing, they look to the societies to say, what is evidence-based medicine and what is best? Do medical directors keep Rolodexes of, what's the pathway for, I don't know, ulcerative colitis? No, because no offense, I'm an oncologist. I have trouble keeping up with what I do,
right.
And don't do that very successfully. But I think that what society, what CMS, what payers do is they look for accredited organizations to say, these are evidence-based pathways and this is what you should use. And I mean, that's what we want, payers and government and everyone else to do. We want the experts to take best knowledge, put it together, and then say, this is how it should be used. But Larry, the other point of view with that, or the other sideline, is that once the guidelines are constructed, they've got to be used, and you have to think about, what's the level of deviation from those pathways. And you can never expect people who are not specialists to be trying to oversee subspecialists. I mean, people don't have that capability. So what people are looking for is the self-regulation of subspecialties and others to say, this is what's best care, this is what's good care, this is what's cost-effective care, and this is what we want our society members to be doing.
Yeah.
Does that make sense?
It does make sense, Roy. It makes a lot of sense. The challenge I've always faced is that we publish guidelines, and whenever I still read all my journals, and when I see a guideline, it's one of the first things I go to review. The problem I struggle with, though, is we don't get feedback back into the societies as to whether that guideline actually resulted in the outcome that it was designed to produce. Mm-hmm. We don't have a feedback loop. And I've always argued for years at the society level that one of the first things we should have done was reached out to the medical directors like yourself, the chief medical officers of the major plans, and say, okay, which guidelines should we be creating? Where are the needs? Because then the payers do have the claims data that could, in one way or another, assist us in determining as to whether the implementation of those guidelines actually resulted in a positive outcome.
So it's interesting you say that, because when you think about guidelines, you go back to some of the early publications from 10 or 15 years ago when, like Atul Gawande and others, would talk about how the surgeons in their operating rooms began to standardize the use of this instrument or that instrument. This is the way of doing this procedure. And there was significant improvement in short-term mortality and complication rates. And then you kind of move over into what the cardiologists did in terms of standardization. Then the oncologists started to do this. And in each time, there was a feedback loop. So in surgery, it was pretty fast. In cardiology, it was longer. But in oncology, it was really related to the drug utilization and side effects and cost.
Yeah.
And I think that part of the whole calculus that we as clinicians need to think about is moving from thinking about that one individual that we take care of as an individual, which is what I want when I go see my doctor, no question. But if I were to go to see someone in Washington, D.C. or Chicago or Seattle with the exact same set of issues, boy, you'd really hope that you can get pretty similar treatment, be it by a cardiologist or a surgeon or oncologist, in any of those places. And so I think part of that feedback loop is actually the standardization itself. And I think the other thing that we don't talk enough about is, by standardization, do we reduce errors in terms of our nurses making fewer errors? Do we make fewer errors? Is it accepted by the practice that you're working in, that it's a standard, so that the nurses and MAs and everyone else knows what's going to happen? And then does that then also result in reduced costs? And I don't think we should shy away from standardization, using evidence-based medicine, and using one of the feedback loops is reducing complication rates and reducing, global costs.
Well, I've been pleased to hear how much you spoke already today before you even used the word cost. And, what I'm hearing from you is that the focus of the chief medical officer for a plan is trying to make sure that the right things are done for the right patients at the right time for the right reasons. And I like your cowboy term. We have to not so much have cookbook medicine so that everybody's forced to follow a recipe, but we all should be able to conform to guidelines so that we can have as much of a predictable outcome as possible when we're providing care. So word quality.
So Larry, I agree with exactly what you said, but when your listeners are thinking about this, remember that whether you're someone at CMS who's thinking about things from a government standpoint, or whether you're thinking about a medical director from a commercial plan, they're representing our neighbors and our people and ourselves. Once the rule is set, say in Medicare, in CMS, it's the same for everyone. I mean, it's not different for Larry or for Roy or someone down the street. The rules are the same, and it's the same thing in terms of commercial insurance. I mean, the plans represent the wishes of the employer groups that people are in. And the employer groups want to keep their employees healthy and functional and everything else. And by the way, the employee groups are the same people who work at HR and the CEO and everyone else at that company. So there is standardization also within the people who, are trying to set policy. They're trying to set policy so that it's equal for everyone, which gets to the point of, equity. And so I just think that's a point for people to remember.
Quality, we've always defined it as or value is defined as quality plus service, divided by cost. And we can certainly measure cost, we can measure service. That quality component is a difficult one to define, but I can see where you have moved in your definition of it, and it is based upon outcomes. So it probably doesn't make as much sense to look for all these process measures unless they're associated with a definable outcome that's good for the patient. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Dr. Roy Beveridge, the former CMO of Humana, and we are discussing value-based care issues from the point of view of the plan. The question of the one patient at a time versus population health. Everything in our training is a one patient at a time training. And, even our EMRs are based upon one patient's record at a time. And in order for us to function the way we have to going forward in value-based care, we've got to look at populations. And the payers have the data on the populations. And I know from our experience at Sonar, when we've been able to share data back and forth, it's made a big difference. How do we make this even more meaningful to be able to utilize what data we have available from the plans and the providers to try to augment the movement to population health?
What's that expression that they talk about now? Data is the new oil, compared to the early 1900s. And no matter how you look at it, data is really important. Who owns that data and how it's distributed is complicated. I think, in this political divide that we have in terms of red and blue, both sides recognize how important data is in medicine. And I think both sides are, trying to figure out how this data infrastructure is used more effectively. Physicians have a lot of data on patients. Hospitals have a lot of data. We've got to figure out ways that the transfer of the data for the benefit of the patient is most important. It's not just going to be the government or the hospitals or the payers or whomever. It's really going to be an effort by the big data companies along with everyone. And I think some of it's going to be some personal responsibility in terms of patients saying, the data is mine, or, the data sits here. And I think we have to be careful for personal rights to make sure that, we're not usurping people's privacy.
Somewhere we have to be able to open the flows of data and still figure out how to protect people's, personal items. The payers know everything that's happening to the patient. The provider only knows what they have in their own EMR, though.
Yeah, the way that I think about it is that the doctors, the hospitals know it really deeply, but it's in a very restricted manner. Mm-hmm. I think the payers understand it in a very broad manner, but not that deeply. Mm-hmm. From a patient's perspective, we really need to make sure that it's held in a compliant manner, but it's used for the patient's benefit. Yeah. And I think that's what society wants. That's what I want, and I know that's what you want.
So when you were at the plan, what kind of data were you looking for that you weren't able to get that would have made your decisions easier?
If you think about gastroenterology as an example, whether you're CMS or whether you're a plan or whether you're a delegated network or whatever, you're really relying on the specialists for specialized, care. Make no mistake, no one at the government, no one in plans, no one elsewhere understands Crohn's, ulcerative colitis, all the complexity around GI disease, like the gastroenterologist. There's such a opening in the world for specialty societies and entities to educate and be responsible in terms of information flow. I don't think, CMS or plans or anyone believe that they're smarter than, GI doctors when it comes to GI issues, or cardiologists with, cardiac issues. They don't. But what I think what society is looking for is, it gets back to the first discussion. What's good quality? And where should we be spending money? I mean, no matter how you think about it, we still, as a society, have a limited number of resources to spend on things. I mean, no matter how you think about it. And we as physicians should be thinking about helping the individual, no question. But we should be thinking about, how we should be helping populations of people in the best cost-effective manner, and making sure that we're doing it in a pattern which is replicatable.
Let's move on to, I wanted to spend a little time on risk management, since that's really what payers do best. They manage that risk. There's been so much consolidation. The plans consolidated 20 years ago, up to 10 years ago or so, and the provider space has markedly consolidated over the last 10 years. Now we have private equity entering in the provider space. We've got plans purchasing providers. Do you have any vision as to what the risk-bearing entity of the future is going to look like?
Is the future next year or 10 years?
10 years. 10 years.
I'm having trouble imagining what the world's going to be like in 5 years later. I think what we can say in 5 or 10 years is, I think you just have to go back to the macro aspects of our economy, which are that, we are graying as a nation. We're living, long lives as a nation. People are stopping work, in their mid 60s or 70s, but they're alive for a long, long, long time.
Let's hope so, Roy.
you and I, absolutely.
Let's hope so.
And then I think chronic illnesses are what is becoming the most important part of our healthcare spend. It's not breaking your arm or having a car accident or random events that happen when you're under the age of 50 or so. It's the accumulated chronic diseases that we're all exposed to, and I would say in GI, when you start thinking about obesity issues and liver disease. I mean, I'm not a gastroenterologist, but I do look at that data and I scratch what little hair I've got left and go, this does not look good. Mm-hmm. So I think that's what I'm much more worried about, Larry, which is how are we going to take care of a very large number of older people with chronic diseases?
So the entity that is most capable of managing the polychronic patients is the one that's probably going to be the aggregatable entity from a business point of view.
And I would say that, so the subsegment of what you just said, which is exactly right, is what entity is going to be efficient and how do you get efficiency? And to get efficiency, you have to start going back to some of the things we talked about, which is pathway usage, because then it's predictable. Usages of, people in the system who may not have gone through 4 years of medical school and 7 years or 6 years of, postgraduate work and things like this. We may need to be using more technology, more, home engagement, and people who are less subspecialized for more general things.
Wow, those were prescient words, because currently today, I think already 83% of the cost of healthcare is in the management of chronic disease. And with the aging population, boy, that's not going to go down. That's going to continue to go further.
Well, I don't know Larry, I don't know what the average age of gastroenterologists is, but I think it's
58.
Oncology, it's like 56 or something.
Yeah.
And I may be off by a little bit, but I'm not off by much.
Yeah.
What is it in GI?
58. The last number I saw was 58. It's scary to think that,
So it's like they better keep propping us up. That's the concern.
Well, do you remember at the end of the 90s, they cut back so many of the specialty training programs because we were all going to become primary care.
Yeah.
That's what was going to happen. And I don't think they ever populated a lot of those programs since then. They're still running at lower levels. So.
But I also think that gets back to the equity issue, which is when you think about where the subspecialists are. I mean, we know the subspecialists are, in the suburbs and the in exurbs, but you get out to rural areas, and I don't know what the numbers are, but look at mental health experts in rural America. I mean, there are just so many states that have so many counties without specialists like mental health people, and that from an equity standpoint, that's a problem.
Those are really, really important points. Roy, I think that's the end of our show today. I really thank you very much for being on. You certainly got me thinking. For the audience, you can learn more about our show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at HCNowRadio. Be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, payers, and plans together to reimagine GI care. Until next time, I'm Dr. K. Stay well. Thanks for listening. I'm Dr. K. Tune in with me next time to reimagine the scope of GI care. If we build it, they will join.